Well, when I was assigned this topic and I looked at who the other speakers were and what their topics were and thought, well, if those are not rare tumors, then what's left? And so I decided that the previous talks must be the medium rare tumors, and now I'll go to the rare tumors. So if you look at the types of tumors for which liver transplantation has been and is performed, we have hepatocellular carcinoma, for which the indications are fairly well defined, hilar cholangiocarcinoma, which is an accepted indication under strict protocols, neuroendocrine tumors, as we just heard from Dr. Habib, hepatoblastoma, which is the most common pediatric malignancy, fibrolamellar hepatocellular carcinoma, and metastatic disease, the most common of which are colorectal, carcinoid, neuroendocrine, and there are case reports of numerous other metastatic diseases for which transplant has been performed. Embryonal tumors, which is only 2.5% of pediatric transplants for malignancy. I've been performing pediatric transplants for 26 years and I've never seen that. And pediatric leiomyosarcoma, which is even more rare. I decided to focus, so other non-malignant tumors are adenomas, hemangioendothelioma, which is important to differentiate from hemangiosarcoma, which has a dismal prognosis, and hemangioma. I decided to focus on 4 rare tumors, and I wanted to just give our experience on neuroendocrine, as that's something that our center has become well known for. Hepatoblastoma, fibrolamellar hepatocellular carcinoma, and intrahepatic cholangiocarcinoma. So the University of Tennessee protocol for neuroendocrine includes pre-transplant screening with triple-phase CT scan or MRI, octreotide scan, and tumor markers, chromogranin, and other markers. We always include resection of a primary with regional nodes, a Ki-67 proliferation index less than 10, although in a couple of cases we've gone less than 20. We exclude poorly differentiated tumors. We pre-treat with somatostatin analogs to inhibit tumor growth, and ablation for bulky tumors, and our preference is Y90. Then we list for transplant 6 weeks after their, at least 6 weeks after primary resection, and assure again that they have no extrahepatic disease by CT and octreotide scan. And then we've been able to get MELD upgrades, previously 22, which was our hepatocellular carcinoma benchmark, and now 28. Our liver transplantation goal is to remove all visible gross disease. We do a bicaval resection with perihepatic lymph node dissection, diaphragmatic resection if it's adherent to the diaphragm, and peritoneal stripping if it's attached. We've also resected omentum as well as partial gastric resection when it was adherent or invading the stomach. Our post-transplant follow-up, again, we scan every 3 months for 1 year and then every 6 months. Our immunosuppression protocol is what I think is very important. We are a steroid-free program for all our liver transplant recipients with rapid HEG induction, 2 doses. But in our neuroendocrine patients, we do primary everolimus monotherapy for all of these patients as primary immunosuppression, and we've been doing that since the New England Journal report in 2011. For recurrence, again, octreotide analogs, chemotherapy, surgical resection is still the gold standard whenever possible, and stereotactic radiation for a couple of patients that have had bone metastases. This is an explant with diffuse metastases, and as Dr. Habib mentioned, these patients generally do poorly, as did this patient, and we would from now on further rule out these patients. Our results, we now have 25 patients over a 9-year period, which I believe is the second largest series in the United States to Dr. Rosen's experience. We have 90% 1-year patient survival, 77% 5-year overall survival, with a 64% 5-year recurrence-free survival, which is similar to the results for hepatocellular carcinoma. It's important, so the question, can we cure it? And maybe in select patients, I believe Dr. Mazzaferro is more selective than we are. However, I recently had a patient return 9 years after his liver transplant with his first recurrence. He had previously had a tail of the pancreas neuroendocrine tumor and had undergone distal pancreatectomy and splenectomy, followed by liver transplantation, and he came back with a left adrenal metastases 9 years later, which we resected. The next tumor I would like to discuss is hepatoblastoma, which is the most common malignancy of childhood, but still only occurs 1 in a million births. Liver transplantation should be reserved for unresectable disease. These are pretext 3, that's pre-treatment extent of disease, which is bilobar disease in at least 3 sections. And this group, classification includes the sections as anterior and posterior right lobe and segment 4 or left lateral segment left lobe. And pretext 4, which includes all 4 of those sections. It can have distant metastases. It may have vascular involvement of hepatic veins, vena cava, or portal vein involvement, and may have extrahepatic involvement. Neoadjuvant chemotherapy is the most important factor prior to transplantation, looking for alpha-fetoprotein reduction and tumor volume reduction prior to transplantation. This is actually a young child, 2 years old right now, that we are evaluating, and this slide shows the tumor prior to chemotherapy. And as you can see, you really can't define the portal vein or the retrohepatic vena cava. Both appear to be obliterated. This is after 2 cycles of chemotherapy. You see recanalization of the portal vein here. You see opacification of the retrohepatic vena cava. And this is another scan post-chemotherapy with further delineation of the main portal vein and visualization of the retrohepatic vena cava. So this child will continue to undergo chemotherapy. He's had a reduction of his alpha-fetoprotein from over 200,000 down to under 2,000, and we intend to list for transplant or discuss live donor when I return. So hepatoblastoma outcomes greater than 90% 1-year survival. Post-transplant chemotherapy is usually considered important. I think the main things with this disease are to avoid salvage transplants, those patients that have had recurrence after a major liver resection, and avoid those children with alpha-fetoprotein less than 100, as this depicts an undifferentiated tumor. So fibrolamellar hepatocellular carcinoma, it's generally considered to be more favorable. It's less than 1% of all primary liver tumors. In a review of the UNOS database, over a 25-year period, there were only 63 transplants performed for fibrolamellar hepatocellular carcinoma in the United States, and this compares to over 21,000 HCCs during the same time period and 620 cholangiocarcinomas. These previous reports had poor results due to large size, vascular invasion, and metastases. So these patients tend to be younger, there's a female predominance, and there have been more live donor liver transplants performed, probably because these patients, while it was thought that it would be more favorable and they could have a good outcome, they were not eligible to meet our UNOS MELD upgrade, and so live donors were performed in these patients. This slide shows comparative survival of fibrolamellar hepatocellular carcinoma compared to hepatocellular carcinoma and cholangiocarcinoma. You see at 1 year the results are actually better, probably related to the better health and the younger age of these patients, and they also usually did not have cirrhosis. At 3 years, the outcomes were fairly similar to those of hepatocellular carcinoma, a little better than cholangiocarcinoma. But then at 5 years, you see a significant decrease in the survival of these patients, and this is related to recurrent disease of these patients. Now moving on to intrahepatic cholangiocarcinoma. It has previously been considered a contraindication for a lot of centers. It may still be. Survival has been reported as 50 to 60% 5-year survival, but most of these patients were transplanted for suspected hepatocellular carcinoma and then only on explant where they found to have cholangiocarcinoma or a mixed tumor of cholangiocarcinoma and hepatocellular carcinoma. And these tumors have a greater recurrence and a lower survival than hepatocellular carcinoma. There's a recent trial going on. This is by the group at Methodist in Houston with neoadjuvant chemotherapy with gemcitabine and cisplatin and gemcitabine and capecitabine. While their overall survival is good with short-term follow-up, they do report a 50% recurrence at 1 year. In summary, hepatoblastoma transplantation following chemotherapy is highly successful, and liver transplantation for these children should really be considered the treatment of choice in unresectable disease that responds well to chemotherapy. Neuroendocrine tumors, transplantation can at least give long-term treatment and sometimes cure. Fibrolamellar hepatocellular carcinoma outcomes should be similar to hepatocellular carcinoma as long as they're transplanted within the same parameters that we use for hepatocellular carcinoma. For intrahepatic cholangiocarcinoma, I think there's promise, but we're not there yet. And sarcomas, the reports of transplantation for sarcomas are dismal with the exception of pediatric leiomyosarcoma. The future direction for these tumors is never say never. All of our current tumors for which we are performing liver transplant have previously been considered a contraindication. The role of transplant oncology is going to be more important as we go forward with a multidisciplinary treatment, including chemotherapy, ablation, and radiation. The advent and discovery of new tumor markers and how these may be used to treat and predict which patients are eligible for transplant. The role of immunotherapy, which has shown outstanding results in some types of tumors, may be beneficial in some of the tumors that we're not transplanting right now. And of course, the expansion of live donor liver transplant, where these patients are not taking away a liver from the pool for other diseases. So, thank you very much.
Thank you for a very informative and comprehensive discussion on a wide range of tumors. Is there any questions or discussion from the floor? I do have a question.
Yes.
With hepatic epithelioid hemangioendothelioma, how do you avoid the rare angiosarcoma?
That's a difficult, very difficult question. In my experience, I have primarily these have been in children, and I've had 50% found out on explant that they were sarcoma. So there are really no tumor markers. It's difficult to biopsy these because of the vascular nature of them, but I think if there's, every one of these now I have a high index of suspicion, and I would proceed to try to biopsy in some way, at least transjugular.
May I ask, James, you mentioned about the very rare leiomyosarcoma in children.
Yes.
The few cases that have been done overall in the world, what does really, if a case will come, you in some ways I never say never. How can we really deal with that?
Well, I think it's a different disease in childhood. And in adults, I've only been able to find a couple of case reports, and they had very poor outcome. And even liver resection for leiomyosarcoma has poor outcome frequently. In pediatric transplants, again, this is a very rare disease that I've never seen in my career. But the few case reports had positive outcomes. Maybe someone in the audience has experience.
Yeah. Okay. Yes, please.
Do you have any experience with ocular malignant melanoma?
I have dismal experience in malignant melanoma. A patient that we thought had hepatocellular carcinoma ended up having melanoma in the liver and died from metastatic disease within 6 months.
What has a cutaneous malignant melanoma, or?
We never identified the primary site of melanoma. I've also had another patient with malignant melanoma that came from a donor source, that it was never diagnosed in a deceased donor, and we resected the melanoma, but again, that patient had metastatic disease and died quickly.
Thank you to all of our speakers and for
Thank
all
you.
of our discussants. Have a good evening.